Good afternoon, everybody, and welcome to Nottingham City Place-Based Partnership, sort of Share and Learn. This is the first of our third series. It's hard to believe we're on our third series now, but delighted you could join us for what are these bite-sized sessions, just telling you a little bit about what's happening across the city in the Place-Based Partnership. Hopefully, grabbing a bit of lunch in the meantime. And for this first one of the third session, I'm really delighted to have Rich Brady, who many of you will know, works very closely with me in the Place-Based Partnership, and Lucy Hubber, who's the Director of Public Health at Nottingham City. And they're here today to talk to us about the new joint health and wellbeing strategy for the city, which I think is really exciting. And actually, the Place-Based Partnership has a real key role in hopefully delivering that. So I won't try and steal all their thunder. So we're going to, as usual in the format of these, have about 20 minutes where Rich and Lucy will present, and there'll be a time for a few questions afterwards. So Lucy and Rich, over to you.
Hi, thanks Hugh, and good afternoon everyone. Some of you may have already heard me speak around the health and wellbeing strategy, and you'll know that I can talk about this for hours and with a great deal of enthusiasm. So I'm going to give a fairly rapid run through and then hand over to Rich, who's going to talk to us about how we're going to go about implementing the strategy. On the next slide, it's worth us just stopping for a moment and reflecting on, just checking we're moving forward on the slides. Reflecting on why we need a health and wellbeing strategy, and number one is because we're told that we have to write one, and very often the strategies are written and we put a lot of work and energy into it, and then they go and sit on a shelf somewhere because it's a document that we're told we have to write. We were very keen with this strategy that, particularly post-COVID and with the opportunities of changing the way we work across the system, that this should be a document that really changes things for our population. And so the strategy sets out that shared vision, and we've spent quite a lot of time thinking about the principles and priorities for action, so that this isn't a document that sits on a shelf, it's a document that we can all say we're contributing to some change in. Next slide, please. You can find the health and wellbeing strategy on the Healthy Nottingham website. There is a PDF that you can download, but it is an interactive website. And also on that website, there are links through of how people can get engaged with things like the Health Champions programme that we're developing as a consequence. Next slide. These are some of the principles that we set out right at the beginning when we were developing the priorities, and right at the top there you won't be surprised to see is reducing inequalities. COVID has shown us it's exacerbated and exaggerated those inequalities in our communities, and really led us to thinking about not just how do we tackle inequalities, but how do we take an equity-based approach in the actions that we want to take over the next couple of years. A fundamental principle is that parity between mental and physical well-being, that we shouldn't be taking action on one without considering the other, particularly important in public health measures, because we know that people don't smoke because they like to smoke. We know that they smoke because it helps them deal with other things in their lives, for example. It's an all-age approach, so it's not just targeting adults or children, and it's got a real focus about prevention. It's saying that actually the sooner we can stop something, the better it is, not just for the person, but the better it is for us as a system as well. We really want to do this with our communities, and we've taken quite a lot of time working particularly with NCVS and Health Watch about how we are going to link in with our communities. And we've said that we want to build it on lived experience rather than some co-production type approach, because we really want to get people's voices in this and make sure that that's very meaningful. Important as well that we recognise that there's a lot of work that how all of these things interconnect, and there's some really fantastic work that's already going on. How can we build on that, and how can we deliver social value so that we're not just doing stuff, but we're doing stuff that can make more of a difference. Next slide, please. So this is the model that we came up with. It places the individual right at the centre of that, and you'll see that physical and mental health have equal parity. And we recognise that change comes to change and adapt their behaviours. And you'll see there that we've got the stages of change cycle. So how do we help people realize that there's something that they might want to change? How do we ensure that they can easily access it? And then how do they maintain that change? But we're not saying this is down to personal responsibility. We're saying quite the opposite, that if we want to encourage people to make that change, we need to create the system around them so that change becomes very easy. And that's what the next 3 tiers of the model are. They've got that prevention approach. They've got considering how and where we should intervene. Do we need to do things at population level? Do we need to make some decisions for our population about the way in which they can, where they can smoke, where they can buy fast food or alcohol, or do we need to work with individuals? And then thinking about those wider determinants. We all know that healthcare is about 10 to 20% of health outcomes. So we need to make sure that we're not just looking about what the health service can do, but what we can all do. How does housing have a role? Education have a role? How do we get people into work and sustaining that work? So that's the model that we base then looking at our priorities. So next slide, please. The priorities really went through a filter. We looked at what all of the big strategic priorities already were amongst key partners. We looked at what the data told us, and I'm going to quickly whiz through some of that in a second. And we also looked at what national legislation and policy was. And that's how we got down to the priorities. We've chosen to only have 4 priorities. It doesn't mean to say that other things aren't important, but we needed to make a start. And because we really want to put energy into these, because we want to make change, had we had lots of priorities, it might have meant that we weren't able to focus on really making a shift. Next slide, please. I'm going to whiz through data really quickly because I want to get to the priorities, but you'll get a feel by looking at it. If we just take healthy life expectancy, which has recently been updated, you can see for both men and women, our life expectancy is significantly worse than the East Midlands, and the East Midlands themselves are significantly worse than the England average. So we've got a really noticeable gap in healthy life expectancy. That's the amount of life that people can expect to live in ill health. And our life expectancy is lower in Nottingham. So not only are people not living as long, but they're living longer in ill health. And that's something that we absolutely need to change. Next slide, please. The key causes of death are those which you would expect to see, heart disease, COPD, stroke. And when we look at the risk factors leading to that, again, it's the usual suspect. It's the stuff that we know that we need to tackle: tobacco, diet, exercise, alcohol use, and really interesting in there for Nottingham, occupation risks. So thinking about the work that people do. Next slide, please. And if you could just keep on clicking through the slides, what we'll see here is that we're worse for smoking, we're worse for obesity, we have low physical activity. Physical activity actually declined during COVID instead of increasing. And then for financial well-being, we're right down there at the bottom. Just Blackburn is worse than us if you map household income against healthy life expectancy. Really clear relationship there between the income of a household and life expectancy. So you won't be surprised then to see these 4 priorities. 2 of them, very typical public health priorities. Tobacco control, so it's smoking and tobacco control, and we've chosen to call it smoking and tobacco control because when we asked questions around smoking, quite a lot of people's smoking behaviour wasn't necessarily tobacco. They considered themselves to be smokers, but they were often adding other things or just smoking something else. And eating and moving for good health, and we've put those 2 together really intentionally because it's not just about physical activity, or it's not just about diet, it's about those 2 things as one picture. And then there are 2 which are really focused around tackling some of those wider determinants. We've got a fantastic programme already about severe multiple disadvantage with the Changing Futures programme, and we wanted to build further on that. And then this very exciting one, which is about financial well-being. And when we spoke to some of the political leaders within the council about what their priorities were, they said the first thing, if you ask somebody what worries them, they won't worry about their weight. What they'll worry about is whether or not they've got enough money to feed their children, feed their family. Have they got a job? Will they be able to go to work? So financial well-being, really important. And you'll hear other words, you'll hear financial inclusion and financial resilience. And we've chosen financial well-being because it's actually the toughest to achieve. It's not just about making sure that people have got access to benefits. It's not just about making sure that people understand how money works. This is about making sure that people are able to make healthy decisions in a way that they are able to sustain their income against the shocks. And over the last 6 months, we've really seen how things like unexpected bills and increases in cost of living have affected our communities. So that financial wellbeing one has become even more important than we expected it to do when we first did this work. Rich, I'm going to hand over to you here, and you can talk a little bit about how we're planning to implement some of this change.
That's great. Thank you, Lucy. Yeah, so some big aspirations, I guess, sort of set out within the strategy. While we've landed on 4 priorities, they're pretty big, and they're not going to be delivered by one partner. And we need a partnership approach. We need all of the different organisations working within Nottingham, pulling in the same direction, focusing on those 4 areas. And what I'm going to talk to you about now is about how we're going to actually deliver on some of those programs. So if we go on to the next slide, please. So just a reminder, I think that some of you may be joining for the first time and not knowing what the place-based partnership is. So just a quick reminder about what it is. It was formerly known as the Integrated Care Partnership, but has now since been renamed as the Nottingham City Place-Based Partnership. And a place-based partnership operates on the sort of same geographical footprint as the local authority. So it covers exactly the same patch of Nottingham City, shares the same boundaries for the Health and Wellbeing Board. So all of these organisations who work within Nottingham have a key role to play in delivering on that strategy. And you can see we've got a wide variety of partners from across the NHS, from local government, but also really importantly within the voluntary sector, housing as well, and of course Health Watch, a really important partner too. On to the next slide, please. So the place-based partnership has been in operation since about 2019, and we've run a series of different programs over the last few years, and we've learned quite a lot about doing that, about how you deliver in partnership. And we know that through what we've done, we are able to achieve much more when we're working collaboratively, when we're all focused on the same objectives, working together, pulling in the same direction. So we're going to apply our approach that we've taken over the last couple of years to the delivery of this strategy. And so each programme, there's an expectation that will be delivered an inclusive partnership approach, and all of the leaders of those organisations that I was just talking through there have committed to resourcing through those programmes to make sure that we've got programme leads backed by teams that are made up of the different partnership organisations that make up the place-based partnership. So that's great. We've got the leadership, we've got the teams in together, but actually what will really make the difference is how we work together, and actually embracing the depth and diversity of the organisations, but also communities within Nottingham. Lucy mentioned the importance of lived experience within our work. We're really majoring on that within this strategy, because we feel that through working through people with lived experience and making sure that we're not just co-producing or consulting with, but working alongside people with lived experience, we're much more likely to be able to come to solutions that are more fit for purpose and are going to have more impact on the health and well-being of people living in Nottingham. So next slide, please. So within each of the programs, there are 3 sort of key roles. So you have an executive sponsor. So there is a sponsor from each of the executive team, so from those different organisations I talked from there, and they are ultimately accountable for the delivery of those programme priorities. We have a programme lead who is resourced from within our different partner organisations. I'll come on to those a little bit later, but they do the day-to-day running of the programs and essentially lead the program on a day-to-day basis. They're supported by program managers who play a really important role in making sure that we're keeping on track within each of our programs. But then we also have a program team. So as I said, those program teams are made up of members of the different partner organisations within the place-based partnership, and working together, we're joining all of our resources together to be able to deliver on these priorities. Next slide, please. So this is a governance diagram. You've always got to throw one organogram into a presentation. So this is it for this one. So you'll see there how we're overseeing the delivery of the strategy. So the 4 blue boxes that you can see there are the 4 priorities that Lucy mentioned earlier. Lucy also talked about the importance of parity between mental and physical health and well-being. And that was a big factor in some of the engagement work we did beforehand, is that people wanted to see mental health apparent within all of the work that we do. So we have a separate mental health program that's not officially part of the joint health and wellbeing strategy programs, but run through the place-based partnership. We have a mental health program that will be feeding into each of the 4 joint health and wellbeing strategy programs. And of course, we know that there are stark inequalities within some of the different communities within Nottingham. We know there's a really high proportion of Black, Asian, minority ethnic citizens within Nottingham, and there are stark inequalities within those different communities. So we need to make sure that we're also considering the inequalities that exist within those communities within our programs as well. So we have another program within the place-based partnership will also be feeding into that. So while the joint health and wellbeing strategy is a statutory responsibility of the Health and Wellbeing Board, the Health and Wellbeing Board has discharged responsibility for overseeing it to the place-based partnership. And so the way in which we're doing that then is we have the programme oversight group, which each of those programme leads from those 6 programmes that you see down there report into. And then what they do is then they assure the executive with all the sponsors on it, who will then provide assurance to the Health and Wellbeing Board for the delivery of the strategy. And then you'll see the dotted line to the Nottingham and Nottinghamshire integrated care system. So not quite in place yet, and of course the Nottingham and Nottinghamshire integrated care system will become in statute from the 1st of July, and it will have within it an integrated care board which will oversee the delivery of NHS services within Nottingham and Nottinghamshire, but it will also have an integrated care partnership which will be the guiding mind across Nottingham and Nottinghamshire, and will develop a strategy for the whole of the patch. And our health and wellbeing strategy within the city alongside the health and wellbeing strategy in the county will absolutely feed into that. So that's how we all fit together as a system. Next slide, please. Now, this is one of the most important things. So delivery principles, and these are these principles are what we've learned from over the last couple of years of delivering our programs, and we have 6. And they are keeping citizens and communities at the centre of everything that we do, making sure that we're data intelligence informed. So, you know, we can start with the data, and as we have with this whole strategy, we started with the data, but that only gives you an indication as to where you need to go. You need to be able to pull in other forms of intelligence, such as, you know, the intelligence from people with lived experience to really help to move us to the next level. We have to be focused on outcomes. What are the outcomes we're looking to see from people? And we need to have equal partners. Each of those partners have different levels of responsibility and different levels of influence. But it's really important that when we're at the decision-making table, that we listen to one another and we feel that no one is bigger than another, and that we all have equal voices when we're going into making decisions. We have to best use the resource. You know, the organisations that are involved within the place-based partnership have got a huge amount of resource. We have to make sure that we're best using it, and we're not duplicating, but we're actually complementing one another through this place-based working. And then finally, the importance of having an evaluation approach from the very beginning, to making sure that what we do, what works really well, we can then roll out into business as usual. A program approach works really well for a while, but actually, if we're really going to fundamentally make a change to health and wellbeing, this should become business as usual for everyone in the city. Next slide, please. So we're coming towards the end of the presentation now. So finally, what I'm going to talk about now is just the delivery plan. So we have to know we're going to be successful, and we have to make commitments. And each of the 4 programme leads for those 4 areas at the moment are currently busily working up delivery plans, which we'll be submitting to the Health and Wellbeing Board, at least initial versions of the delivery plans. And they will have objectives within them across the 1st, 2nd and 3rd phase. And there's a reason it says phase instead of year. It's a 3-year strategy. It might be quite neat to say 1st, 2nd and 3rd year, but actually we know that some of the areas that we're trying to tackle are going to take a lot longer than 3 years. But it's really important that we have sort of indicative milestones that we're working towards, so that we make sure that we're working towards the overall goal. And actually the overall goal is a long a long way away perhaps is to increase that healthy life expectancy and life expectancy. But we have to know, we have to achieve a lot of other things to know that we're actually going to get there in the end. So that's pretty much it. The next slide is a bunch of email addresses, and of course we'll make these slides available as well. But these are the people who are leading on those 4 programs. So you've got those there, and of course I chair the oversight group, so I'm sort of responsible for the delivery of the strategy overall. So if you have any questions about any of those individual programs, you can get in touch with the program leads or the strategy or delivery of that at all, then you can get in touch with me. I think the next slide says thank you very much for listening, and back over to you, Hugh. I think you're still on mute there, Hugh.
I am indeed. Yes, thank you, Lucy. Thank you, Rich, for sort of galloping really through what was quite a big topic, but you've just managed it in just a fraction over the 20 minutes, so well done. That's an outcome we like, so that's very impressive from that side of things. Couple of questions that were lurking around, and some of you've touched on, because you just touched a little bit on that success sort of stuff, but 2 things I'll pick up, perhaps I don't know who wants to pick this one. Obviously sort of our frontline staff buying into this is really sort of critical to the sort of success, and it's probably fairly easy for the people heavily involved in the programs going to be about. But how have we given any thought to how we're going to really get our wider sort of staff to sort of think and buy into this in any way? I don't know if anybody wants to take that.
I can go first if you like, Lucy. Yeah. So it's a really good question, Hugh, isn't it? Because we can have these quite focused programs, but they will be really focused actually. And I guess one important thing to say is, just because we're focused on these things, it doesn't mean that there are not lots of other things happening elsewhere. And that doesn't mean that there are other pieces of work aren't important. But in terms of how we're going to involve other members of staff within this, I guess it's an open invite for everybody to be involved. We're not going to be able to deliver on these programs unless we have really wide support and engagement from people within our partnership organisations. The leaders are able to give strategic direction and are able to say where they think their organisations are able to contribute, but they're not the ones who are able to do the doing. So we're really clear on the fact that if we don't have the buy-in from staff to be able to deliver on these programs, then we're only going to have some limited success. So it's really up to it's really up to others to want to get involved, and we really want to encourage that. And that's, I guess, why Lucy and I are really keen to do sessions like this, is to promote the strategy and promote the involvement of people from across the partnership.
Thanks, Rich.
I would just add to that, if I can, Hugh, that there's been some really important discussions about the role that the ICS can play in tackling inequalities, and we've spent quite a lot of time trying to work that through. And what we've come to is that the ICS can really influence that equity argument about how do we make sure that we have to do a little bit more, or a little bit different for some people to give them the same chances as other people to access services. And that's where it will really filter down to frontline services. When you're thinking about your service, actually, have you asked yourself a couple of key questions? Do you understand your population? Or have you looked at the people that are being referred to you, or the people that you're treating, and do they represent the population? And if not, why not? And are there other barriers that we're putting in place for some of our good reasons that actually might make it more difficult for people to access some of our services? So I'm hoping that that whole kind of way of thinking will begin to get embedded, not just through the health and wellbeing programme, but through taking that approach through the way that the ICS is configuring itself as well.
Thanks, Lucy. That's really helpful. And then another little one, sort of on the same vein, because you mentioned the wider determinants, housing, work, and sort of stuff. And obviously, through the place-based partnership, we have links into the health and care sector. But obviously, the city and our populations are more than that. Have we sort of started to have any thoughts about how we might reach out to non-traditional partners? You know, there's some pretty big private sector employees and stuff in the sort of city, they could have a real help focusing, I suppose, in sort of helping us deliver some of that they have reached to different people. I mean, it's obviously early days from the strategy, but is that in scope, do you think, or have you had any thoughts on that one? I'd just be interested in your views on, because that's an area that we've not really been good at getting into in the NHS, particularly before.
It's an incredibly important point. I think it goes two ways. There's something about, we describe ourselves as anchor institutions, but are we truly anchor institutions, or are we just local employers? And so there's some work that we need to do of ourselves to think about what are we doing to support the wider determinants and work with our population. And that's a piece of work that we've just started. So we've brought in a consultant in public health to work across the anchor institutions to be looking at that. The place that we've started in terms of engaging with wider business is the financial wellbeing element, and connecting very strongly with the financial resilience partnership, which is already made up of several of the large employers and the large finance companies, and working with them to begin to bring in that more health and wellbeing element into the financial resilience part. And that's going to be a bit of a proof of concept. Plans in the eating and moving well, absolutely, about how we might work with some of those large employers. But the first starting point will be in financial wellbeing, where people like Experian are already key partners in the delivery of that.
Thanks, Lucy. And sort of, just going back, sort of, Rich, that success had some slides with some nice green boxes, but actually in little detail. When do you think we might start to sort of shape what the sort of success will actually genuinely look like? Do we have a timeline for that? Have there any thoughts on that yet?
Yes. So as I said in the presentation, that the programme leads are currently working to develop their delivery plans for each of those programme areas. And I think we've tried to be really ambitious with this and have delivery plans that we want to submit towards the Health and Wellbeing Board at the end of July. I think they're well on the way with developing those. Actually, one of the really important things that I think we have to consider within partnership working is that we make sure that we have buy-in across of our different partners for what we want to achieve. And that's a really important thing about the strategy as a whole. Actually, we took our time to work out where we all wanted to focus, not where one part of the system wanted to focus, because we're much more likely to be able to achieve things if we're all starting from the same position and wanting to, and all agree on where we should be going. So the initial plans is to have some initial delivery plans submitted to the Health and Wellbeing Board at the end of July, but we're going to be continuing to develop those because, as I say, we don't want to, I guess, set things before all partners have been properly engaged in the strategic direction of those programs. So they will be iterative delivery plans, and of course that's a really important thing around program delivery as well, is you don't just submit a plan and then that's the plan. You keep going back to it, you keep reflecting as things change, and that's what we'll continue to do as a partnership, and the Health and Wellbeing Board will absolutely hold us to account for that.
Thanks, Rich. One final quickie. Somebody just popped something in the sort of chat. Tackling financial wellbeing is great priority, as we've noted, but how confident are you that partners within the PPP and the wider ICS might take the issue of raising pay for the poorest seriously?
It's a really important question, and it comes back to that anchor institution bit. Is before we can talk to other people about it, actually, have we got our own houses in order? How are we being, and this is probably a slightly naughty response from me, is working with us as organisations to have we properly considered the real living wage and what that means for our population. So we all have. It's a brilliant challenge, because it's a question we should be asking ourselves, and we should have a good answer to how we're addressing it. Whilst we're beginning to see, healthcare providers beginning to have like food banks for staff, actually, are we addressing some of the underpinning problems there, some of the more structural elements to it? So it's a really good challenge. It's a challenge that I'm already taking very seriously, and happy to come back on and talk about when we've had a chance to fight that corner a bit.
And I just say, as somebody who's worked with Nottingham citizens around the living wage and as a living wage practice, absolutely on my agenda, certainly from that point of view. So time's up. We've had a half an hour. So thank you very much, Lucy and Rich again. Hope people have enjoyed that. As we've noted, we will share the slides. This has been recorded, so hopefully some of you might be able to get it on catch up as well. And as ever, from all of us, if you have any questions or queries, don't hesitate to just drop us an email and we'll happily have a conversation, because this is all about reaching out and making this all our priority. So thank you very much and have a good afternoon, everybody.